There are a number of questions, and I think what we may need to do is perhaps try and answer these offline for everybody by maybe putting the questions and the answers on Hoover, but I'll talk to you guys offline. That said, there are two fundamental themes that are going through lots of the questions, and I think I'm going to ask each of you an opinion on each of those two questions. The first one relates to how we encourage primary care, community care, whether it be physicians or whether it be maybe nurses or others that are working in the community, to really get more involved and want to be responsible for looking after people with EDS and HSD. So I'm going to come over to Dr. Hart first of all. How do we encourage more people to be more interested in primary care?
So I think, hear me, I think one of the issues is with primary care, they may have one or two people in their practice that has chronic healthcare needs. And so it's going to be hard for the patient to really pull them in and get them interested. In many respects, I think it's as specialists, it's our role to make sure that they understand what's going on with the patient and help encourage them to do the things that the patients need. And reach out to me. I have a lot of them that reach out to me when they get a patient like this to help start the process.
Thank you. Dr. Rudin, with your experience of working with clinicians, do they reach out to you now? Are they starting to ask you questions?
They do. I get a lot of calls frequently. I have this patient, I think they have this condition, where can we get started? And now I have some materials I can point them to. We also have an e-consult service, so somebody can actually float a question electronically, and anything that says EDS on it, for better or worse, goes into my inbox. And so I try to help that way as much as I can.
And there was a question about whether the facility that you've put onto Epic could be available for anybody who uses Epic. Is that possible?
I don't know. It was an in-house build for UW Health. What I can say, and it was one of the slides that got left off because I had the old version, any healthcare provider or organization can get the written guideline. Right. And I've asked Faye Moran to post as a PDF the new version of the slides, and the last slide will have those details.
We'll share it, absolutely, thank you. Dacre, from your perspective, I know you've had questions in the past about how you get the networking into the community. How does it work for you at the Mayo in terms of encouraging primary care to get more involved?
Well, yeah, I mean, that's a big question, and I think it's improving. I mean, the primary care doctors are knowing a little bit more that these conditions are out there, their patients are educating them. I think we had some presenters share the same experience I had, that at times in some of these situations, you all know more about these conditions than some of the doctors you see, and you educate them. And they then by turn know that there are some colleagues that they need to refer to or speak to. So it grows. It's a work in progress. I think it's a lot of good work that's being done. This is where the research comes of great importance too, because I think these conditions in some ways are so mysterious but so connected with so many other things that the more we learn about them, there'll be great inroads into other general major conditions in healthcare care altogether.
For our therapy colleagues, one of the things that we talk about a lot in ECHO is the experience that therapists have in actually negotiating with doctors, just generally. But I wonder what your experiences are of dialogue with primary care and their engagement and responsiveness to you.
I find that if you're not a physician, it's very hard to speak with physicians. Right. I find there are certain types of physicians that, such as physiatrists, family medicine, that can be a little bit more open, specializing physicians, right? So I work a lot with the Penn MS Center here at University of Pennsylvania Hospital. And so, I will always reach out to physicians with the patient's permission, but I don't always get a response. I've met neurologists who have told me, physicians don't want to talk to non-physicians. And so know that it's a challenge for us, but that doesn't mean that we're not trying and that we're not going to continue to try. I know from my end, and especially when, physicians are sort of at the end of their rope, they don't know what to do. And so they do want a little help, but they don't always know where to turn themselves.
Right.
Yeah.
Aiko.
Oh, I agree with that. It is oftentimes really hard to have that conversation. Recently I've been doing a lot of letters that really sort of summarize, and I also kind of try to sprinkle in some, peer-reviewed journal articles to just kind of show, hey, there is a lot of research around this. I wonder if you're aware of that. I always have my couple of favorite articles that I love to send to, providers that I think, might not necessarily understand that this is, something that needs to be treated, needs to be attended to. So, I think just putting that in the communication with the provider, even if I don't get a call back or any correspondence back, my hope is that, eventually at some point they'll be like, oh, I got that letter from, oh, I got this, I got that. Maybe I'll go back and take a look at that if it comes down to it. But it's challenging for sure.
Yeah, no, absolutely. And I think one of the things that we see happening more and more in the ECHO programs is with the whole principle of all teach, all learn. There's no hierarchy here, right? Yeah. But it is nevertheless something that's really challenging for you guys in the therapies, and I think it kind of feeds back to that whole primary care perception that you have to feed up to the specialist. Actually, no, we can all be generalists and all be good at it. Thank you very much for those. I want to take this time now for the second question, which again kind of sums up a lot of questions in here, and it's all about trust, which is it encompasses a huge number of different facets, and being gaslit. So the general question is, have you ever been in a position where you have done something inappropriate for your patient and lost their trust, and then been able to resolve it? And how did you do that? I'm going to start over here with you, Aiko.
Yeah, so I would say, that's a really good.
It's a real good question.
It's a really good question. It's a really good one. I think, I can't think of anything specific, but I feel like it always comes back to listening. Like in the first panel, I remember someone said that and I was like, oh, that's so true. Because I think a lot of times as providers, we get into this very analytical mode. We're like, okay, they checked this box and so I'm supposed to do this and this is supposed to go this way. But, I think if your brain is too caught up in that, you forget to listen, really listen, to think about what this patient is telling you, what's important to them. And so I think it's a matter of, when you get into that mindset of oh, they followed this, algorithm and I'm supposed to do this, and you sense some resistance from them, you have to step back as a provider and say, okay, this may not be appropriate for this patient. Let me hear a little bit more about what's going on. What do I need to change here in order to move things forward in a way that it's really about care that's a partnership rather than I'm going to tell you what to do,
right.
So, yeah.
That very paternalistic model you were showing. Dacre, your experience.
Yeah, I would continue on that, and I think this happens to all of us, that we misstep, we misspeak, we have misplaced expectations both from physicians and patients. I haven't been to Philadelphia in a while, but when I was thinking I was coming to the city of brotherly love, and as I'm driving around like an absent-minded Floridian getting honked at, I didn't realize that the love was just a form of honking. And so it maybe it is, just expectations that we as physicians can understand that patients are coming in with, or what they want out of the visit. And likewise, for patients to know what this physician specializes in, what is the limits of their knowledge, and what is kind of the course of therapy that they're used to giving. Knowing those things, I think, helps prepare for the trust issues to be balanced better.
Right, and it feels like a harsh question to give to a panel that's full of passion and compassion. Yeah. But I also figure that if we can just be very honest and show how we reset, all that should do is really help everybody else to feel safe in the same space. I remember once being told, oh my goodness, I was told you were an angel and I believe you're an angel. How on earth did you make that mistake? And it's kind of like, well, okay, I'm human. I'm not an angel, right?
I was once told by a particularly annoyed Wisconsin farm woman, you're as useless as udders on a bull. Every once in a while you screw up. And in that particular case, I was able to say, what's going on here? What are you looking for? What didn't happen? And she was able to tell me, and we were able to negotiate it, and we were able to move forward. It doesn't always work, I try to remember to say a few things, like we said earlier, I don't know. Second, I'm sorry.
Right.
And not, okay. And not, I'm sorry to hear that, because that means you don't like having heard the news. A patient taught me that distinction, but I'm sorry that happened, whether I had anything to do with it or not. And try to rebuild rapport. I confess it does not always work. Sometimes, what people want and what they expect is not what you're actually able to deliver. But I try and set the stage by saying, okay, what do you most want to get out of being here? Yep. And that at least gives me an idea how to proceed.
Right.
And I try to go from there. But none of us is perfect.
No, and I guess that fits in with the authenticity part of it, to be able to just say, I'm sorry, and work out how you then move on together. Thoughts from your practice?
I would say a couple of things. So in therapy, we talk about something called tear and repair. Which is the idea that we can kind of like when you're working a muscle, right? That you can have a tear and you can apologize. You can say, I'm sorry, maybe I screwed up, maybe I'm missing you here. And I think that does go so far with people. And also this piece of listening, just to echo. I think on the gaslighting piece, I want to add something too, which is a lot of the people living with EDS and hypermobility happen to either be women or people who are born identified female at birth. And it's very important for everyone who lives with this condition, but particularly those folks to, recognize this happens a lot to me as, again, as a woman or as a person who has been identified female at birth, and or maybe female presenting. And so it's very important to, recognize when you are being gaslit by a provider, to, put a pause on something and explain, I don't like how you're speaking to me right now, or I'm feeling frustrated with this interaction, something, and really let that provider know, I feel like you're not hearing me. I'm not getting something I need from this, and go see someone else as needed. But I'm so glad in our society that some of these issues are coming up more, that we have more language for these things, because it is so important, particularly for that population of people, and also for people of color as well.
Absolutely. No, thank you for that. And I'm going to deliberately segue for the last 30 seconds to the cis white male for the final word.
Yeah. And actually, the times where I've had difficult interactions and people lose trust really have come around oftentimes medications. I have a young trans male who was getting admitted to the hospital on a regular basis, getting IV pain medications. And I was trying to convince him that going to the hospital and getting these medications in the long run was not helping him. And he took that as me not believing that he has pain.
Right.
And basically the way we repaired the relationship is that I apologized that he misunderstood what I was trying to say. Interestingly, he's still going to the ER. They're not admitting him all the time, but he has a lot of mental health issues that really interact with his pain. And he also has a home life that is horrible and is really creating a lot of those mental health issues. And acknowledging that, understanding his story and acknowledging those problems goes a long way with repairing.
Well, look, we've come to the end of our session. I think on behalf of everybody, I really, truly appreciate both your expertise and your compassion and your passion for this. Thank you so much, everybody, and I really hope you've enjoyed the first session today.
Thank you.
Do you want to head off?
Nice to meet you.